Begin the award paper session. Yeah. I call upon Dr. Pavitra to present the paper.
Good afternoon. I am presenting a case report of azathioprine and resistant type 1 lepra reaction. Borderline tubercular Hansen's disease occurring in immunocompetent individual. Nerve involvement is common. This type of leprosy affects an individual depends on immune response mounted against the organism. Complicated by immunological phenomena called reactions, up to 30% of borderline disease experience type 1 reversal reactions. And type 1 reversal reactions are immunologically mediated episodes localized in skin, nerves or both. Type 1 reactions are the major cause of nerve function impairment and main treatment options are steroids and chloroquine. 40 years old female from Mangalore presented with complaints of asymptomatic reddish patch over right side of face which was progressive in nature since 1.5 years. Previously diagnosed a case of borderline leprosy with 2+ slit skin smear and treated with MBMDT for 1 year. During the course of treatment, patch became edematous and erythematous without nerve involvement and history of taking steroids for 8 months with no improvement. On examination, there was edematous well-defined plaque of 7 into 3 cm with peripheral faint whitish scales over right side of cheek extending below the right temporal hairline into just above the angle of right mandible, which was not warm and tender without eye involvement. Repeat biopsy done showed borderline tubercular with negative white stain and slit skin smear negative. Then she was started on prednisolone, clofazimine and chloroquine and which was continued for 3 months. Patient showed very minimal improvement. These are the pictures taken during treatment with steroids and chloroquine. Then patient started on azathioprine 50 mg OD, then gradually increased to 100 mg along with the chloroquine, following with gradual decrease in color and edema of the plaque. These are the pictures taken during treatment with azathioprine. There is a gradual decrease in the color and edema of the plaque. Glucocorticoids are the main therapeutic agent in leprosy reactions. Some patients have prolonged reactions and require prolonged therapy with corticosteroids. Corticosteroid sparing agent used especially to reduce the doses or alternative to steroids or reduce the side effects. There are few reports on the use of azathioprine in type 2 lepra reactions. There was only one control study carried out with type 1 lepra reaction. In that study, azathioprine was used for 8 weeks with prednisolone. They found it was effective as prednisolone alone. Prednisolone and chloroquine are the mainly used in treatment of type 1 reactions, but our patient failed to respond both of these drugs, so intensity of the patch remained the same, but started responding to azathioprine reasonably. Azathioprine, through its active metabolite 6-thioguanine, incorporates into the DNA and RNA, thereby inhibits the purine metabolism and cell division. It affects both B cells and T cells function and antigen presenting cell function and the numbers, thereby altering the antibody production. In this way, it's helpful in a type 1 reversal reaction. In this case, patient failed to respond to conventional treatment but started responding to azathioprine. So we propose that azathioprine can be used in resistant type 1 lepra reaction, but the drug have to be tried in more number of cases. These are the serial pictures taken during the treatment. These are my references. Thank you.
Thank you, Dr. Pavitra. Now moving on to the next paper, I request Dr. Ragini to present the paper.
Good afternoon, one and all. I'm here to present a case report on borderline tubercular leprosy that developed type 1 reaction and deformity during postpartum period. Leprosy, a chronic infectious disease, is predominantly a disease of skin and peripheral nerves, but quiescent nature of the infection and lack of overt symptoms mask these occurrences. Several diseases have an altered course during pregnancy and puerperium because of metabolic changes, increased secretion of steroids, and altered immunological response during pregnancy. We report a case of BT Hansen's disease with type 1 reaction that developed during the postpartum period. Coming to the case, a 20-year-old female patient, resident of Guntur district, a housewife, presented to DVL OPD with chief complaints of reddening of lesions over left cheek and forearm since 5 months and deformity of left hand since 3 months. The present complaint started 2 years back as a hypopigmented patch over left cheek. During pregnancy, in the 5th month of gestation, she developed a new patch over left forearm. She neglected both of them and did not take any treatment. Following 4 weeks after delivery, she developed reddening of both the patches. History of loss of sensation is present. 2 months later, she noticed a deformity of left hand, which was causing difficulty in daily activities. There's history of formation of spontaneous blisters over left hand since 1 month. No history of patches elsewhere on the body, and there's no history of fever. Her past personal and family history were nil significant. General examination was normal and vitals were normal. Coming to cutaneous examination, 2 lesions were noted, one over the left cheek and other over the left forearm. There was a well-defined erythematous round plaque with sloping edges measuring approximately 5 centimeters into 6 centimeters present over the left cheek, extending over the nasolabial fold, upper lip, angle of the mouth. The other lesion was on the left forearm. It is a well-defined large plaque of size 20 centimeters into 4 centimeters over lower part of left arm and covering anterior and lateral surfaces of left forearm with sloping edges and tiny erythematous papules along its borders. Both the patches showed dry surface, decreased sweating and decreased hair. Sensations of touch, temperature and pain were lost over palmar and dorsal aspect of left hand. Sensations diminished over both patches on cheek and forearm. There was no glove and stocking anesthesia. On motor examination of muscles supplied by ulnar nerve, there is wasting of hypothenar muscles. Partial claw hand was present and Fromen's book test was positive. On examining median nerve muscles, thenar wasting is present. Pen test was negative and Osner's clasping finger test was also negative. Examination of nerves. Ulnar nerve was enlarged on left side. It was a mild enlargement, firm in consistency. There is no nodularity and tenderness was present. Superficial radial cutaneous nerve is enlarged on the left side and it is non-tender. Facial nerve was not appreciated. Other nerves examination was normal. There is no evidence of trophic changes. Oral mucosa, nails and genitals were normal and there was no systemic abnormality. A clinical diagnosis of BT Hansen's disease with type 1 reaction with partial claw hand was during postpartum period was made and investigations were sent. Slit skin smear was negative and a skin biopsy was done. Discussion. Rai has said 70 years ago that leprosy does not have the slightest effect on the course of pregnancy, but pregnancy has a marked effect on leprosy. This holds true even today. The first case series of reactions associated with pregnancy was published in 1975. Reasons for altered course of leprosy in pregnancy include metabolic changes, steroid secretion, and immunological response. There is relative and absolute malnutrition seen in pregnancy. It causes inhibition of rosette-forming T lymphocytes and thus there is depression of CMI. Levels of free cortisol and 17-hydroxycorticosteroid increase during pregnancy and may be partly responsible for depression of cell-mediated immunity. Pregnancy and puerperium are associated with biphasic responses in both humoral and cell-mediated immunities. During pregnancy, there is increased humoral immunity and thus type 2 reactions are more common. In postpartum, there is increase in cell-mediated immunity, thus type 1 reactions are more common. 20 to 30% women develop signs and symptoms of pregnancy for the first time in pregnancy or shortly thereafter, and this has been attributed to decreased CMI in pregnancy, resulting in increased bacillary load. A compounding factor for this could be the reluctance of women to take medication during pregnancy. In our case, the patient had Hansen's disease before pregnancy in the form of a single patch, which she neglected. During pregnancy, disease activity has increased and led to the development of a new patch, but even then she did not take treatment. Following delivery, she started developing type 1 reaction as evident by reddening of the lesions. Finally, she landed up in deformity and only then she consulted doctors for treatment. Had she taken treatment for leprosy before and during pregnancy, she would have avoided developing the deformity. In general, drugs are best avoided in pregnancy, but the benefits of treating leprosy during pregnancy far outweigh the risks of the drugs. Dapsone, rifampicin, and clofazimine are category C drugs and can be given. Quinolones, minocycline, clarithromycin should be avoided. In conclusion, there is an increase in bacillary load during pregnancy due to suppression of cell-mediated immunity. Reactions occur more commonly during postpartum period, which may be due to recovery of cell-mediated immunity in the face. WHO recommends that pregnant women with leprosy should continue to take standard MDT. Thank you.
Thank you, Dr. Ragini. We shall move on to the third case report. I request Dr. Rajat Raj to present the paper.
Good afternoon, everyone. I will be presenting a case of histoid leprosy, presenting with myositis as a part of type 2 Leprosy reaction. The case was a 31-year-old male hailing from Kasaragod who came with the presenting complaints of a painful swelling over the upper left arm since 8 days, painful reddish raised lesions over the arms, legs, back, and face since 5 days, fever with chills since 5 days. The painful reddish lesions were transient and new lesions occurring every few days. There was history of asymptomatic raised skin lesions over the back and arms since 1 year, for which no treatment had been taken. There was history of numbness over the forearms and hands, as well as joint pain since 1 week. There's no history of eye pain or any nasal symptoms, and no history of any wounds over pressure-bearing areas. General examination revealed the patient to be febrile. Systemic examination revealed no abnormalities. On cutaneous examination, there was a diffuse swelling with overlying erythema measuring about 8 into 4 centimeters over the posterior aspect of the left arm around the elbow. It was tender and with a local rise in temperature. There was also multiple erythematous tender nodules, which were firm in consistency, seen over bilateral forearms, the back, and over the face, some of which showed signs of pustulation and ulceration. A few asymptomatic hyperpigmented nodules and erythematous plaques were also seen over bilateral arms and trunk. Infiltration was seen over the ears and face. Picture depicting the swelling over the left arm. Infiltration seen over the face, over the ears. A few nodules seen over the lower forearms and the rest of the forearms. On closer view, we see that some of them show signs of pus formation. Nodules seen over the lateral aspect of the arms as well as over the trunk. A closer view of the lesions over the trunk. A few of the lesions have ulcerated as seen over the right knee. Coming to nerve examination, there was enlargement and tenderness of bilateral ulnar nerves, the common peroneal nerves, as well as the posterior tibial nerves. There was enlargement of bilateral radial cutaneous nerves, as well as the greater auricular nerves. There was reduced fine touch and pain sensation over medial aspect of bilateral forearms and hands, and over the plantar aspect of both feet. Motor examination was normal. Picture depicting the thickened greater auricular nerve, which is visible. Investigation revealed a mild anemia, as well as raised total count and neutrophilia. There was a raised ESR. A slit skin smear showed a bacteriological index of 3.4. Histopathology. Biopsy was done from 2 lesions. The first was a hyperpigmented nodule over the back, which showed features of thinned out epidermis, a Gren zone, extensive dermal infiltrate which extended to the deep dermis. Abundant foamy histiocytes and spindle-shaped histiocytes were seen. A 5 stain was positive. The second biopsy was done from a tender erythematous nodule over the right arm, which showed a focal loss of rete ridges, a dense infiltrate which consisted of macrophage aggregates superimposed by a dense neutrophilic infiltrate with a few lymphocytes. A diagnosis of histoid leprosy and erythema nodosum leprosum were given for the first and second biopsies, respectively. Treatment was started in the form of multibacillary multi-drug therapy. Steroids were given along with thalidomide. Antibiotics included third-generation cephalosporins, and analgesics in the form of tramadol and paracetamol were administered. The patient developed increase in pain and swelling over the left upper arm within a week of admission. An abscess was initially suspected. Ultrasonogram revealed myositis of the left triceps. The patient also developed sudden clawing of hands and feet, the left foot in particular, within 2 weeks of admission. The picture depicting the before and after development of ulnar claw hand, as well as foot drop of the left foot. A diagnosis of histoid leprosy in severe type 2 reaction with myositis and multiple nerve fallacies was given, which resulted in bilateral ulnar claw hand and foot drop of the left foot. Coming to discussion, type 2 leprosy reaction is a type 3 hypersensitivity reaction. Erythema nodosum type lesions are the major clinical skin lesions seen, hence also known as erythema nodosum leprosum. It usually occurs in the lepromatous spectrum of leprosy. Now, myositis is one of the manifestations uncommonly seen in a type 2 reaction. There are very few reported cases of myositis occurring in type 2 leper reaction, especially under the histoid variant. It may be associated with concomitant arthritis in 28% of cases. It may be due to muscle invasion by extension of the subcutaneous nodule. Involved regions are usually woody hard and movements are very painful. Nerve damage may occur in type 2 reactions. It usually occurs due to an inflammatory edema and result in compression of the vasa vasorum. Added compression may be due to nerve entrapment over prone areas such as the ulnar groove and carpal tunnel. It results in nerve function impairment. A severe reaction is seen by swollen and tender nerve trunks with loss of function. Associated skin involvement is not always seen. Thank you. These are my references.
Thank you, Dr. Rajat. Now I call upon Dr. Preeti Naik to present a case.
Good afternoon, everyone. The case which I am going to present today is nasal leproma, a rare presentation of Hansen's disease. A 37-year-old female patient came to us from Kannur. She had chief complaints of swelling and pain of the nose since 10 days and obstruction of the nasal cavity since 10 days. Patient presented to the ENT OPD with swelling and pain on the left side of the nose and nasal obstruction since 10 days. There was no history of epistaxis. A clinical diagnosis of rhinoscleroma was made and biopsy was taken. She also had an asymptomatic raised lesion on her left foot for which she was referred to dermatology OPD. Patient then presented to us with asymptomatic raised lesion on the left foot since 1 year. Initially it was small in size. It gradually progressed to present size of P. Over the next 6 months, she developed newer small raised lesion on both leg and forearm. There was history of dryness of skin over both lower limbs since 1 year. There was no history of contact with Hansen's disease, and there was no history of hoarseness of voice, anosmia. Past history, there was nothing significant. Treatment and family history, there was nothing significant. General physical examination was normal. Systemic examination, all the systems were normal. Then on nasal examination, there were multiple nodules present over the septum and the inferior turbinate of bilateral nasal cavity. Crusting and synechiae were present. Nasal mucosa was thickened and pale. There was no visible nasal deformity and there was no destruction of the inferior turbinates. This is a picture. The upper picture shows a nasal nodule over the septum, and the down picture is the endoscopic view of the left nasal cavity with multiple nodules. Cutaneous examination, there was few discrete erythematous to hyperpigmented nodules which were present on the dorsum of the left foot. The largest one, which is shown in the picture, measuring around 2.5 to 2 centimeter. There were also multiple skin-colored papules present on bilateral leg, feet, forearm and nose. Bilateral ear infiltration was present, and on nerve examination, right lateral cutaneous nerve and the left posterior tibial nerve were enlarged. Sensory and motor system was normal. A provisional diagnosis of Hansen's disease, lepromatous leprosy type, was made. Then we sent for investigation. The slit skin smear showed a bacteriological index of 6+, and there was mild anemia with HB being 9.1 gram per dl. Leaving that, rest all the investigations were normal except for LFT, which was slightly dearranged. This is the histopathology of the biopsy from the lesion or the nasal septum. This is a low power picture showing squamous metaplasia. This is the picture of the same specimen. This shows the nasal mucosa. This shows the foamy macrophages, and these are the mucinous glands. This is the high power picture of the same specimen with foamy macrophages, with the nucleus is pushed to the periphery. And a Phyte Farrakhan stain was made, and it showed clumps of leprae bacilli. This is again a histopathology of biopsy which was taken from the skin on the left foot. This low power picture showed Gren zone, a clear Gren zone, and also the foamy macrophages. The high power picture showed a thinned out epidermis, Gren zone, and also the foamy macrophages. And this is the Phyte Farrakhan stain of the same specimen which showed clumps of leprae bacilli. So after this, we confirmed the diagnosis, and a final diagnosis of Hansen's disease of lepromatous leprosy type was made. Okay, discussion. Leprosy is a chronic granulomatous condition caused by Mycobacterium leprae, an acid-fast bacillus. Nasal discharges from untreated lepromatous leprosy patients who are often undiagnosed for several years are the main source of infection in the community. Mycobacterium leprae, once inhaled, multiplies on the inferior turbinates and has a brief bacteremic phase before binding to the Schwann cells and macrophages. Earliest intranasal change specific for leprosy is pale, often yellowish thickening of the mucous membrane. The nasal obstruction in lepromatous leprosy reflects extremely heavy granulomatous infiltration of the mucosa. Barton reviewed a series of 77 patients with lepromatous leprosy and found that 94% complained of nasal symptoms. Out of that, 66% of the people had nasal obstruction. Mycobacterium leprae usually involves intranasal structure without any relationship to clinical disease, which can occur even before the skin lesions. So it is interesting, despite high prevalence of infiltrative nasal mucosa by bacteria, occurrence of leprosy with intranasal manifestation as primary symptom of the disease is very rare. Treatment, we started the patient on multibacillary multidrug therapy for 1 year, and the patient is on regular follow-up. In our patient, we found it was lepromatous leprosy presented with nasal leproma. So I conclude here that leprosy even today presents in various less common and different ways. Healthcare specialists, especially the otorhinolaryngologist, should suspect leprosy in patients who have nasal lesions. These are my references. Thank you.
Thank you, Dr. Preeti Binayak. Now I call upon Dr. Hashba to present the paper.
Respected Chairperson, judges, faculties and delegates, a warm good afternoon to one and all. I'm here to present a case titled Unusual Case of Multibacillary Leprosy. A 65-year-old male patient, a resident of Kannur, presented to our OP department with complaints of 2 red raised lesions over the dorsal aspect of right hand of 3 months duration, numbness over the ulnar side of right hand of 2 months duration, and a single flat lesion over the dorsum of right hand of 1 month duration. There was no history suggestive of motor weakness, no history of contact with Hansen's disease cases. He is a known case of coronary artery disease on medication and gives a history of road traffic accident 35 years back, following which there was a flexion deformity of the right little finger. General examination and system examination was within normal limits. Cutaneous examination showed 2 well-defined erythematous, shiny, non-tender plaques with irregular border over the ulnar side of right hand and little finger, and a single ill-defined patch with wrinkled surface over the dorsum of right hand. Temperature, pain, and fine-touch sensations were impaired over the ulnar side of right hand, extending to the little and the ring fingers. No feeder nerves were palpable, and the right ulnar nerve was thickened but non-tender and non-nodular. Thus, a clinical diagnosis of Hansen's disease borderline tuberculoid was made. On investigation, the slit skin smear examination revealed a bacteriological index of 3+ from the plaque and 1+ from the patch, while negative from routine sites, and a morphological index of 80%. Histopathological examination showed features of epidermal atrophy and the presence of Gren zone,